Assalamu alaikum wa rahmatullahi wa barakatuh. I welcome you to the third revision session of the endocrinology course in the fall semester of the year 2025. A quick reminder of the ground rules by which we should abide all through the session. Please, at all times, keep your microphones mute to lessen the background noises and echoes. Whoever wants to ask or to make a comment or to make a suggestion, please raise your hand and then open your microphone. Okay, but for heaven's sake, don't talk all of you at the same time so that I can understand what each and every one of you is saying. I'm opening also my video camera in order for you to see me, but by now you know already who I am. Okay. Feel free. We are all sitting comfortably at home, so feel free to eat and drink during the session. Okay, and whenever you want to break, just let me know. All right. Okay. And by the end of today's session, I'm also asking you to fill out a survey like the last times in order to for me to improve my online teaching. All right. The survey doesn't take that long, but it's really very important for me that you fill it out. Now let us start. I suppose my slides are visible. Okay, it's okay, Dr. Sama. Are my slides still visible to you?
Yes, Doctor.
Yes, Doctor.
Okay, Dr. Sama told me that there was also a problem in the first revision session. It did not open, so I need to check out my connection. Maybe something went wrong while I was uploading it. Okay, so I'll try and do that, inshallah. All right. So the intended learning outcomes of today's session are the following. By the end of today's session, you will be able to list the symptoms and signs of Cushing syndrome. You will be able to understand the various imaging modalities in Cushing syndrome, namely pituitary MRI, as far as Cushing's disease is concerned, CT adrenals, as far as CT causes, adrenal causes of Cushing syndrome are concerned, and octreoscan. I will explain to you what that is. And then you're going to be able to list the symptoms and signs of Addison's disease. You're going to be able to understand the various imaging modalities in Addison's disease, namely plain X-ray of the abdomen, as well as CT on the adrenal glands. You're going to be able to list the clinical manifestations of pheochromocytoma, and you're going to be able to understand the various imaging modalities in pheochromocytoma, namely CT, adrenal glands, MRI of the adrenal glands, MIBG scan, very important, and the MIBG SPECT CT fusion scan. I'm going to explain to you what that means when we reach there. All right. And you're going to be able to list the clinical manifestations of Conn's disease or primary mineralocorticoid excess. Enumerate the biochemical investigations of Conn's disease, and you're going to be able to understand the various imaging modalities in Conn's disease. Again, CT adrenal glands and radioactive iodo nor cholesterol scan. All right. This is what we're going to cover today. So as far as Cushing syndrome is concerned, on this slide are summarized the clinical manifestations of Cushing syndrome. Usually the patient is a female and she is complaining of maybe she has amenorrhea, okay? And she complains of abdominal stria rubra. Remember, anything that has to do with the external appearance of a patient, female patients notice immediately. She will complain also of moon faces with a buffalo hump, and I'm going to show you what the difference between those is. She complains of obesity, particularly truncal, affecting the chest and the abdomen and the thorax or the trunk. And she complains also of thin, wrinkled skin, purpura, skin ulcers with poor wound healing, muscle weakness, and she is hypertensive. She may have also cardiac hypertrophy. She has osteoporosis, and she has emotional disturbances. Okay. And if you do imaging on the cella turcica, you may encounter enlarged cella turcica, although 90% of the ACTH secreting pituitary adenomas are microadenomas, that is less than 1 centimeter in all directions. And if the patient has an adrenal problem, an adrenal mass or adrenal hyperplasia will be visualized on adrenal CT. Okay, so this is the summary, a quick summary of the clinical manifestations of Cushing's syndrome. Okay, as you know, the clinical manifestations include symptoms, which are the complaints of the patient, as well as signs. So in the complaints, the 91% of patients complain of weight gain, right? Weight gain. 84% of female patients complain of menstrual irregularities in the form of either oligomenorrhea or even amenorrhea, complete cessation of menstruation. Okay, 81% of female patients again complain of hirsutism. As agreed before, hirsutism is applied only on female patients, and it means what? Who can tell me? Who can tell me again the definition of hirsutism? I have told you this before. What is the definition of hirsutism? Who can tell me? What is it?
Growth or appearance of hair in male pattern hair development on a woman.
Yes, it has to be terminal hair. Huh? You have to add terminal hair. So by definition, hirsutism means growth of terminal hair in androgen-dependent areas in a lady. Okay, so this occurs in 81% of Cushing syndrome patients, and 2/3 of the patients have psychiatric dysfunction in the form of depression, in the form of elation, euphoria, whatever. Okay, but depression is very common actually. 43% of patients complain of backache. Who can tell me why? What is the cause of backache? Who can tell me?
Osteoporosis.
Yes, actually, osteoporosis per se is a painless condition, but once it causes compression fractures, for example, in the lumbar vertebrae, backache starts to occur. Okay, this occurs in 43% of patients. And actually, I have seen a patient, a female patient with Cushing syndrome. She was 35 years old. She had all the full-blown picture of all the symptoms and signs of Cushing syndrome. In addition, she complained of backache together with severe weakness in the lower limbs. Not only weakness, but also numbness and tingling and so on. So we did a plain X-ray on her lumbar spine, lumbosacral spine, and it turns out that she had severe osteoporosis, which led to compression fracture of 3 lumbar vertebrae. And these compressed the spinal cord, leading to this severe weakness. Because you see, muscle weakness also is a symptom of Cushing syndrome in 29% of patients. And it has a high discriminant index, 8. Discriminant index means it aids in the diagnosis. It's very important in the diagnosis to discriminate Cushing syndrome from other causes of muscle weakness. Okay, so although only 29% of Cushing syndrome patients complain of muscle weakness, but it has a high discriminant index. All right. So the patient I was telling you about just now, she had this muscle weakness due to Cushing syndrome, as well as due to the compression fracture that occurred in her lumbar spine due to the severe osteoporosis caused by Cushing syndrome. All right. Fractures are present in 19% of patients, like in the patient that I mentioned just now. And 13% of patients complain of loss of scalp hair. Okay, now coming to the signs. These are the clinical findings that you as physicians detect while examining the patient. Obesity. Obesity is found in almost all patients, 97%. But mind you, we keep saying truncal obesity, but in what is recorded in the epidemiological studies is actually that 55% of patients complain of generalized obesity, like simple obesity, exactly, okay? And only 46% complain of truncal obesity, which is deposition of fat or redistribution of fat in the thorax and abdomen of the patient, okay? 94% of patients have plethora. Plethora. What is meant by plethora? Who can tell me? What is plethora? What is plethora?
Facial flushing or redness?
Yes, it's not flushing because flushing actually is by active vasodilatation, but this is not. It's not like that. It's redness. The patient is red in the face, like I'm going to show you in the pictures. Some people, lay people, they say وشها بيبك من دم من كتر الصحة. This they equivalent this redness, excessive redness in the face, with signs of health, but actually this is a sign of illness. Okay, moon phases occurs in 88% of patients. Who can tell me the difference between face, F-A-C-E, and faces, like it is written here? I think I told you this before, right? Did I tell you this before? Who can tell me the difference? Is there a difference?
Faces is facial features.
Yes, exactly. Facial features of acromegaly. So moon faces means that the face of the patient is rounded, very much rounded, like the moon on the 14th day of the Hijri or the Arabic month. All right. And hypertension is seen in 3/4 of the patients. And bruising or excessive hematomas, they are found in 62% of patients, and these have the highest discriminant index of 10.3. You see, so first bruising and then the muscle weakness. All right, so bruising here, it is important to ask the patient whether she hit herself or she was subjected to trauma before developing this bruise, because otherwise it won't be significant if it followed trauma. Okay. The red purple striae, the typical red purple striae, are seen in only 56% of patients, and their discriminant index is not very high. Okay, as you can see. And you see here muscle weakness, although in the complaints they were seen in only 29% of patients, here 56% of patients, if you in 56% of patients, if you examine their muscle power, particularly of the flexors, extensors, abductors, and adductors of the shoulder and hip joints, you will find weakness. Okay, and ankle edema is present in 50% of patients. Who can tell me why? Why is there ankle edema in Cushing syndrome? Why? Why is there ankle edema? Cortisol in excess has also some mineralocorticoid action, so it tends to cause like sodium and water retention. Okay, so this is why ankle edema occurs. And pigmentation is seen in only 4% of cases. Do you expect to find pigmentation in all types of Cushing syndrome? I mean, in all causes of Cushing syndrome? What are the causes of Cushing syndrome? Who can tell me? Yeah? How do we subdivide the causes of Cushing syndrome? Yes, tell me. Yes, go ahead.
Okay, there would be probably central, that is pituitary. Then there's adrenal cause, and then exogenous causes, and maybe ectopic.
Okay, so we tend to, yes, this is another subdivision. Very good, Dr. Maliso. Actually, we subdivide the causes of Cushing syndrome into ACTH dependent and ACTH independent. The ACTH dependent causes, they are dependent on presence of ACTH, all right? Among them is, of course, the ACTH secreting pituitary tumor, as well as the ectopic ACTH secretion, all right? So the adrenal causes, they are put among the ACTH independent causes. Okay, so where do you expect to find the pigmentation? In the ACTH dependent causes or in the ACTH independent causes of Cushing syndrome?
ACTH dependent.
Yes, of course. Very good. Because why? Was it Dr. Nadine? Why, Dr. Nadine?
ACTH triggers melatonin production.
Yes, yes. Actually, the father hormone or the father molecule that produces melatonin and ACTH and melanocyte stimulating hormone in animals, because it is said that melanocyte stimulating hormone doesn't exist in humans. So it is called what? Pro-opiomelanoprotein. You see, so pro meaning it's a prohormone, and opio because it's also the parent molecule of opioid hormones. Okay, melano from melatonin, cortin from ACTH. Okay, so in ACTH dependent causes of Cushing syndrome, the ACTH is high, so it can cause pigmentation, and this is one of the important signs that we shouldn't miss. Okay, very good. But there are also other findings in Cushing syndrome, like, for instance, diabetes. And here we don't say it is primary diabetes. No, it is secondary diabetes mellitus. It occurs in 50% of cases. But mind you, only in 13% is it overt, meaning that the patient complains of polyuria, polydipsia, loss of weight, etc. But in 37% of patients, they have impaired glucose tolerance. So here you have to do the oral glucose tolerance test in order to be able to diagnose it, right? But you have to know about it. I mean, you have to put it in mind that you have to look for it if you don't find the patient to be diabetic. And the other 50% of patients with Cushing syndrome have osteoporosis, like I mentioned, and 15% of Cushing syndrome patients have renal calculi. All right? Okay, so let me show you some pictures of some Cushing syndrome patients. You see, this is a baby. Huh? He's not just obese, no, but he has, you see, he has this moon faces, and he has also the facial plethora. But he is also obese. You see the skin folds all over the body. And this is a young gentleman. This is the picture before and after treatment. Before treatment, you notice the moon faces and the facial plethora, very evident. And after treatment, you see the facial plethora became much less, and the face returned almost back to his normal. But he has also abdominal stria rubra that are not only found on the abdomen, but they are also found on the axillary folds and till the cubital fossa. And it is said that after treatment, the stria rubra, they don't totally disappear. They improve, but they don't totally disappear. So here is to show you moon faces. All right. Okay, these are two patients. This is a young male patient, and this is a young female patient. They look similar to each other, right? But they are not brothers and sisters. They are not cousins. They are not even related. What are the common characteristics seen in both of them? Who can tell me? Who can tell me? Can you still hear me?
There's a plethora, there's moon faces.
Yes, yes.
And although you can't see the entire body, but there are elements of, I mean, increased weight gain. What is that?
Okay. Okay. Anything else you want to add? Okay. Type. يبقى like Dr. Molisi has said, both of them have moon faces. Okay. Both of them have facial plethora. You see, the face is very red. Okay. And here, this is the area of the supraclavicular fossa. Fossa should be concave like that, right? It should be a depression. Now, where is the depression? It is filled out by a supraclavicular fat pad here as well. Okay, so this is, don't tell me this is a buffalo hump. No, the buffalo hump is seen on the nape of the neck, not in the front. This is a supraclavicular fat pad. Okay, now notice this black line here on the chin of this lady. What is this? This is one of the androgen-dependent areas. So this is hirsutism. This is terminal hair on the patient's chin, right? So here I wanted to show you moon faces, the facial plethora, as well as the enlarged supraclavicular fat pads. This is, you see, this is the buffalo hump. Okay? The buffalo hump, in order to say that the patient has a buffalo hump, you have to look at the patient inside view like that. But here, since the buffalo hump is very large, you can appreciate it by looking at the back of the patient. It is present at the nape of the neck and at the upper back. Okay, but usually if the buffalo hump is small, you can only detect it by looking at the patient inside view like that. All right, is it clear the difference between buffalo hump and supraclavicular fat pads? Is it clear?
Yes.
Okay.
Yes.
Okay. Now, this lady, I'm telling you, she's a lady. Why? Because she's wearing a nice pink nightgown with nice lace. Very, very elegant, actually. But suppose, imagine you are covering the patient's body and you are looking only at her face. Would you say this is a female or a male patient? What do you think? Just cover up the male, right? Why? Because first of all, she has short scalp hair, but not only that, she has also temporal recession, bitemporal recession of the scalp hair, like in men. Okay, and she has a beard and a mustache. This is hirsutism, actually. Huh? She has also the moon faces, but here she doesn't have plethora. She appears to be a bit pale. So maybe this lady had a malignant cause of Cushing syndrome. So this is to show you the moon faces and the hirsutism. All right? So far, any problems? Now, this is a gentleman, a young gentleman with Cushing syndrome. Of course, here the genitalia are covered for privacy, but then who can tell me the rest of the signs that we can detect in this picture? The signs of Cushing syndrome. Who can tell me?
There's abdominal stria. The muscles, thigh muscles seems to be a bit of wasting.
Yes, very good.
And then there's central obesity as well,
Yes.
and general obesity.
It's not general. Why? Because here, if you look at an obese person, you will find the thorax and the abdomen obese, but the upper limbs and the lower limbs as well, they will be obese, right? But look at this patient. Here, you mentioned first central or truncal obesity. You were right. So here, the thorax and abdomen, they are very obese compared to the limbs. You see, the upper limbs and the lower limbs, they are very thin. They appear very thin, right? So this is truncal obesity. Okay, what else? Now coming to the thorax, here you see the breasts of the patient. Does he have gynecomastia? Yes or no?
Looks like gynecomastia.
It looks like. Okay, looks like. So the next question, how can we differentiate between true and false or pseudo gynecomastia? Pseudo, it's written P-S-E-U-D-O for false. How can we differentiate clinically? Clinically, by doing what maneuver?
بنحط الاندكس فينجر كده لو حسينا الرب يبقى ديت سودو لو ما حسيناش الرب.
Can you please repeat in English? Dr. Moaliso doesn't understand Arabic. Can you please repeat in English? Who is it?
We put the index finger.
Yes, you put the index here on the nipple, right?
Oh.
Okay, and then what?
If we felt the rib, so it is gynecomastia.
True. It's true.
true gynecomastia.
If you felt the rib,
لا no. If
you
we
got me
felt the rib,
confused. أيوة.
if
Then
we
what?
felt the rib, then it's false. يعني
Okay.
pseudo gynecomastia.
Okay, it's fat يعني. Then it's fat. Okay,
yes.
very good. But if you feel what? If you feel what, it is true gynecomastia. If you feel what under your index finger?
breast tissue يعني
Yes,
disc
exactly.
breast tissue.
Exactly, very good. Very good. Who answered بقى? Because I don't know your voice. Who answered?
دكتورة هبة.
Huh? Dr. Heba, very good, Dr. Heba. So, like Dr. Heba mentioned, by Dr. Moaliso said that it looks like gynecomastia. So, in order to differentiate between true and false gynecomastia, like Dr. Heba said, we put the index finger here on the nipple of the patient and we compress. Okay. If you feel the rib under your index finger, then this was fat tissue. This is pseudo or false gynecomastia. But if you feel a disc of breast tissue intervening between your index finger and the underlying rib, this is true gynecomastia. All right, is it clear? Any problems? Very good. Type, what else? Here you can see the patient has a lot of bruises in his legs. And if you ask the patient, did you hit your legs? He tells you, no. This is the first time I see these bruises. So these are the ones with high discriminant index, okay? And the skin appears to be thin and atrophic and scaly. And there seems to be a wound ulcer with, skin ulcer with poor wound healing. And he has also ankle edema, particularly here on the right side. And like Dr. Moliso mentioned, he has muscle wasting. He is a man, right? Men are usually muscular, yani they don't have to be necessarily as muscular as Muhammad Salah, yani, huh? But at least you see the quadriceps femoris is very much atrophic here. And the deltoid, you see, where is the roundness of the shoulder? Here it appears like a square, like it's flat. So the deltoid muscle is also wasted. All right. So most probably this patient will also complain of muscle weakness, proximal muscle weakness. So here I wanted to show you the easily bruised, thin, wrinkled skin, the abdominal stria rubra, the proximal muscle wasting and myopathy, as well as the ankle edema. Okay. And here, these are two patients with Cushing syndrome. Here you can see the truncal obesity of the lady. She has a very large belly, and the breasts are also enlarged with some abdominal stria rubra. Here you can see this bruise, okay? And when you ask the patient, what is this? Did you hit your arm? She will tell you, no, I don't know. This is the first time I've seen it. I don't recall having hit my arm somewhere. So this is spontaneous bruising. This is the one with the high discriminant index. And this is another patient with another bruise. How come this bruise appears dark bluish brown in color while this one appears pink in color? Why? Who can tell me? Depends on the age of the bruise, right? Initially, the bruise, once immediately after this appearing, it appears dark blue in color. And then the hemoglobin liberated in the tissues is going to be broken down bit by bit. So over the days, the color changes from dark blue to bluish green, then to bluish greenish brownish in color. Then it's going to fade day by day until it becomes pink like that, and then it disappears. All right. So here is to show you the bruising of the skin without obvious injury. Okay. Here these are two pictures. This is a female patient showing the abdomen of a female patient. How do I know it's a female patient? Because the pelvis appears gynecoid, you see. She has a broad pelvis. And you know that in ladies, the pubic hair should be triangular with the base of the triangle upwards. But here there is hair rising to the umbilicus, like in men. So this is another one, a site for androgen-dependent areas, one of the androgen-dependent areas. And she has extensive abdominal stria rubra. And the typical stria rubra in Cushing syndrome should be wide and thick like that, 1.5 to 2 centimeters thick. and the skin overlying appears to be thin and atrophic, right? And the stria are purple in color. These are the typical abdominal stria rubra, or the typical stria rubra present in Cushing syndrome. And this is here a male patient. How do you know it's a male? He doesn't have any breasts, but it looks like he has gynecomastia. Most probably this will be pseudo or false gynecomastia. If we compress on the nipple, we won't be able to feel a disc of breast tissue under the index finger, okay? And here he has a pot belly, the protruding abdomen like that, with a lot of abdominal stria rubra, wide, thick, purple red in color, and they are extending even to the lumbar region and to the back, okay? Mind you, stria rubra, they appear first on the abdomen, but if they are extensive, they can occur also on the lumbar region, on the buttocks, on the thighs, on the breasts, on the anterior and posterior axillary folds, till the cubital fossa, like we have seen in the very first patient, and in the lower limbs, maybe till the popliteal fossa as well. All right, so this is to show you the abdominal stria rubra. All right, now these are two patients. This is a young gentleman, and this is a female child, a girl. They look very similar, right? But he's not her father, he's not her elder brother. They are not related. But what are the points of similarities in both patients? Who can tell me? Yeah. Who can tell me?
moon faces
Yes.
والfacial plethora
Yes.
وtruncal obesity.
Yes. What else? Very good. Very good. What is this?
دي ulcer, big ulcer.
No, it's not an ulcer. Actually, if you look closely, it's a large hematoma, or a large bruise, and he has applied some Thrombex or Hemoclar ointment on top. Okay. Top. What else? What else? This one here. This is another hematoma, but this one may be related to sampling of blood from the cubital fossa. This one appears to be spontaneous. And there is also ankle edema, particularly in the little girl, very evident. Okay. And what else? This truncal obesity, it appears while the limbs are relatively thin, it appears as if they look like a lemon on a stick. You know the lemon, lemon al-adalya? If you put it on a stick, on a barbecue stick, it will appear like that. All right. And here, note please that this little girl may have short stature, because cortisol in excess inhibits linear growth in children, right? Always remember that. So this is to show you the lemon on a stick appearance, the central obesity, like you have mentioned, and don't forget short stature in children. Okay? Any problem so far? Have you seen actually in the ward any Cushing syndrome patient?
Yes.
Please. Okay. What signs did he show? Was it a male or a female patient?
Female.
Female. What signs did she have? What signs of the signs I've shown you?
She
What
had
did she?
stria rubra, truncal obesity.
Yes.
I think she did have the buffalo hump as well, and the
Yes.
moon face.
Mm-hmm.
She had a fungal infection due to.
Okay. Very good. Very good. She didn't have any
She had
hirsutism.
the operation and she was fine.
Sorry?
I don't remember her status. She had an
Okay.
operation. I don't remember the type of Cushing, but I remember she had an operation and she was fine
Okay.
after that.
Okay, great. Okay. So now coming to very good, very good. Thank you very much. So imaging in Cushing syndrome, this is very important. Remember, the pituitary ACTH secreting microadenoma is the cause for pituitary Cushing, what we call Cushing's disease. Okay, so here the imaging of choice is MRI scan of the pituitary gland. Don't tell me MRI brain, because if you write in your request MRI brain, the radiologist will do all the scans, all the possible views of the brain except those of the sella turcica. So you have to specify in your request MRI pituitary or MRI sella turcica. Okay, so the classic features of a pituitary microadenoma are, like I mentioned before, a hypodense lesion. This one here, you see, after contrast. This is the area of the pituitary. Let me revise the anatomy again. This is air in the oropharynx. This is air in the sphenoidal sinus. This is the pituitary gland. Notice that the upper border of the pituitary should be normally concave or flat, but here you notice it is convex, all right? And the pituitary stalk normally should be central. Here you notice it is deviated to one side, and this is the optic chiasma, and this is the suprasellar cistern. And here is the cavernous sinus on the right side, and this is the cavernous sinus on the left side. So this is an MRI of the pituitary gland. T1 weighted image because the CSF appears black. Okay, coronal section, coronal, cut like that along the coronal suture. So it shows a hypodense lesion after contrast. Contrast given is gadolinium, associated with deviation of the pituitary stalk to the left side, all right, and an upper convex surface of the pituitary gland. These are the classic features of a pituitary microadenoma, right? We have discussed those before, I think, right? And this is the CT of a normal adrenal gland. This is the axial cut like that, transversely, okay? And this is the coronal cut, okay? So let me show you the anatomy. This is posterior, this is anterior, this is right, this is left, because in the axial cut, they cut actually the patient's abdomen like that, and they look at it from the patient's feet. So this is right, the right side of the patient, this is the left side of the patient, okay? Bone appears white, so this is the vertebra. And these are the ribs on the left side, these are the ribs on the right side, okay? And this is the liver on the right side. This is the spleen on the left side. This is the abdominal aorta, okay? And here is the right crus of the diaphragm. And this is the left crus of the diaphragm. Why is it important to visualize these structures? Because the adrenal gland, the normal adrenal gland, this is the right and this is the left. Normally, if you measure the thickness of the medial limb of the adrenal gland here and there, it should be less than the thickness of the relevant crus of the diaphragm. So this is the right adrenal gland. It appears like an inverted Y or an inverted V shape. If you look at the medial limb of this right adrenal gland and you compare it to the right crus of the diaphragm, you can see that it is half its thickness. So this is normal, right? And this is the left adrenal gland. It appears like an inverted Y or like a Mercedes sign. If you look at the medial limb of the left adrenal gland and compare it to the left crus of the diaphragm, it is also half its thickness. So again, this is normal, right? So far, any problems? Let's look at the coronal cut or the coronal section. Again, this is the diaphragm. The crus is here. This is the crus, okay? And this is the crus of the left crus of the diaphragm. Here is the liver. This is the spleen. And this is the what? Stomach, okay? Here is the left kidney. And this is the right kidney. Here you can see this is the right adrenal gland, like an inverted V. And if you compare the thickness of the medial limb to the right crus, it's like almost half of it, right? And this is the left adrenal gland, like a Mercedes sign. If you compare the thickness of the medial limb to the thickness of the left crus, again, it's half its thickness. So this is how a normal adrenal gland looks like on abdominal CT. Any problems so far? Huh? Any problems?
Well
All
understood,
right.
Doctor.
Okay. Now let us look at some pictures of CT scans of adrenal glands of patients with Cushing syndrome. Before saying what you see in any imaging modality, please mention the type of the imaging. This is what, a CT or an MRI or what? And mention also the the cut. Is it axial? Is it coronal? Is it sagittal? Is it without contrast? Is it with contrast, with intravenous contrast only, with oral contrast only, with both intravenous and oral contrast? Okay, and then mention what you see or the pathology. Okay, so here let me explain to you. This is a CT abdomen, adrenal protocol or axial cut on the adrenal glands showing this is the posterior aspect. So this is the lumbar vertebra. This is the abdominal aorta. And here they have administered both intravenous and oral contrast to the patient. How do I know? Because here you notice the abdominal aorta appears bright. It's white, okay? So it means it has taken up the urographene. And also this is the liver. You see the portal tracts are all white. This means that it has taken up the intravenous urographene, right? Why did I say they have given oral contrast as well, or gastrographene? Because here you see these are the loops of intestine. There is a white shadow. This white shadow is the gastrographene, and the black shadow, this is the air inside the loops of intestine. Okay, so this is the abdominal aorta. So this again, this is a CT abdomen, axial cut, adrenal protocol, or at the level of the adrenal glands, with intravenous and oral contrast showing. You see here, this is the right adrenal gland. It's bulky. Why? Because this is the right crus of the diaphragm. This is the medial limb. It's like 3 times the thickness of the right crus of the diaphragm. And this is the left adrenal gland. If you compare the medial limb to the thickness of the left crus, again, it appears like 3 or 4 times the thickness of the left crus of the diaphragm. Okay, and this is the upper pole of the right kidney. This is the upper pole of the left kidney. Okay, and here is part of the spleen. So this is a case of Cushing syndrome due to bilateral adrenal hyperplasia. Is it clear? Any problems? Any problems so far?
No.
Good. Okay, let us look at this CT. This is a CT abdomen, axial cut at the level of the adrenal glands. Okay. Here, did they give intravenous contrast or just oral contrast? Who can tell me?
Just IV دكتور.
No,
لا هو
they
ما
did.
فيش contrast خالص.
They didn't give intravenous contrast. They gave only oral contrast. How do I know? Because the intestine is filled with gastrographene, the white area, alternating with the black area of air and stools. Okay, so let's check the anatomy again. This is the vertebra. These are the ribs on the right side, the ribs on the left side, and this is the abdominal aorta. It doesn't appear bright like in the previous picture. Okay, it's just gray in color. And this is the right crus of the diaphragm. This is the left crus of the diaphragm. This is the liver on the right side, and this is the upper pole of the right kidney. And here you can see the right adrenal gland. If you compare the medial limb, the thickness of the medial limb to the thickness of the right crus, it's normal. It's half its thickness. But here, this is the right, the left kidney. I mean, the left kidney, and all of this, you see, all of this is what? It's an adrenal adenoma. If you compare this to the thickness of the left crus, it's almost 10 times thick as. So this is a case of Cushing syndrome due to a left adrenal adenoma. Is it clear? So far, any problems?
Clear,
Any
doctor.
problems? Okay. Now, this is a very interesting CT abdomen. Again, axial cut, adrenal protocol, or at the level of the adrenal glands. Here they have given both IV and oral contrast. Why? Because the abdominal aorta appears very bright, and the liver as well. This is the liver. So this is the abdominal aorta. This is the right crus of the diaphragm, the left crus of the diaphragm, the vertebra, the right ribs, the left ribs. And this is which structure? I didn't tell you about the structure before. This is what? What structure is that? in front of the abdominal aorta. Exactly. This is the very good. This is the pancreas. And these are loops of intestine filled with gastrographene, the white, alternating with air, the black. Okay. Now, let's look at the black arrows. They are pointing at these two structures. What are those? If you look closely, these are multilobulated structures or macronodular. They contain macro or big nodules. This is a big nodule here, there, and there. If you compare the thickness of this structure to the right crust of the diaphragm, it's almost like 5 times as thick. Okay, so this is a hyperplastic right adrenal gland, and the same applies to the left adrenal gland. This is it has a big nodule here, macro nodule there, and there, and the whole thickness of the left adrenal, it's like 5 to 7 times as thick as the left crust of the diaphragm. So this is a case of Cushing syndrome due to massive macronodular adrenal hyperplasia. This is a very rare condition. I have seen actually 2 cases only since 1991 till now. Okay, so this is a very important cause of Cushing syndrome that should not be neglected. Okay, and they consider it. They can put it. Some textbooks put it in the ACTH independent causes, and some other textbooks put it in the ACTH dependent causes, so as not to be confused. Yeah, huh? Okay, because it starts as ACTH dependent, but then it becomes autonomous, so it becomes ACTH independent. So both are correct. Okay. Anything that is not clear? Let's proceed. Now, this is a close-up of an abdominal CT, axial cut, adrenal protocol, showing this is the abdominal aorta. Did they use intravenous contrast or just oral contrast, or both intravenous and oral contrast? What do you think?
Oral only.
Yes, exactly, because the loops of intestine are filled with gastrographene, which appears very white in color, alternating with the air inside the loops of intestine, which appears black. And this is again the pancreas, all right? This is the abdominal aorta. This is the right crust of the diaphragm. This is the left crust of the diaphragm. This is part of the liver. This is the spleen. Here, the adrenal, the arrow points at this, you see? This is the right adrenal gland. If you look closely at the medial limb of the right adrenal gland, you will notice it appears somewhat thicker than the right crust, right? But not only that, it appears beaded, right? As if it is like a sepha, huh? Like a paternoster. You see, it has beads. A micronodule, another micronodule, another micronodule, another micronodule, and another micronodule. Here, the left adrenal gland is not visualized as far as I can see. So this is a case of what Cushing syndrome due to primary pigmented nodular adrenal disease. I have also seen only one case. Why do they call it pigmented? Because actually on naked eye, after they remove this adrenal gland and they look at it, it's pigmented. The adrenal gland has a lot of pigment in it. Okay, is it clear? So this is how it looks like. Now coming to this CT, again it is a CT abdomen axial cut, but is it at the level of the adrenals, or is it higher up or lower down? Who can tell me? The anatomy has changed, right? Where is the abdominal aorta and where are the crura of the diaphragm? All we can see is this is posterior, this is anterior, A for anterior, R for right, L for left. This is the body of this is the lumbar vertebra most probably, okay? And here is the inferior vena cava. This is the abdominal aorta, right? This is the right kidney already visible, cortex and medulla, and this is the left kidney about to finish, cortex and medulla, okay? And these are the loops of intestine filled with gastrographene. Here they gave only oral contrast, okay? And now what are these structures on both sides of the body of the vertebra? These structures, what are those? You can tell me. Huh? These are muscles, the psoas muscle. And here, these are the erector spinae muscles alongside the spine of the vertebra. And all this is the subcutaneous tissue of the anterior abdominal wall, and this is the subcutaneous fat of the posterior abdominal wall. All right? Now, what is the white arrow pointing at? This is a very large structure, globular structure, heterogeneous in nature. You see, here there is an area of breaking down which appears darker than the remaining of the structure. Here they have put like a scale. This scale is 5 centimeters long. This tumor appears more than 5 centimeters in size. So most probably this is Cushing syndrome due to right adrenal carcinoma. Okay, and this is the same, the CT abdomen of the same patient, but at a higher level, at the level of maybe the lower. It's also an axial CT at the at the lower thorax, upper abdomen, right? So here you can see this is posterior, this is anterior, this is right, this is left, this is the vertebra, these are the ribs on the right side, these are the ribs on the left side, this is the left lung. It's black because it contains air. This is the right lung, and right lung recess. It's also black because it contains air. This is the start of the liver. Okay, and here the white arrow points at some structures that are similar in density in Hounsfield units to this structure. So this is these are liver metastases from the right adrenal carcinoma. And here you can see the portal tracts with contrast in them. Is it clear? So it depends actually on where you are in the body. How can we detect that? Because on CT they provide us in one of the films with the key. The key is the patient upright, and there are several lines. Each line is marked on one side by the number of the cut of the scan. And if you want to know where you are, you look at the key. This is scan number 100, for example, and this is scan number 100. So you know where exactly you are on the patient's body. Is it clear? So these are large liver metastases from an adrenal carcinoma. Actually, I have seen 2 cases of adrenal carcinoma in my life. Both of them were young male patients. The first one was 35 years old. He had a left adrenal carcinoma, which metastasized to the spleen and the liver, proven by biopsy, tissue biopsy. Actually, he wasn't operable, so we tried to bring mitotane from abroad, but unfortunately, the patients passed away before mitotane even arrived. All right, mitotane is a drug used for medical adrenalectomy, right? And the other patient was a young gentleman. He was 17 years old. He had a right adrenal carcinoma, exactly as big as the one I showed you. And he had also several liver metastases. Of course, it was also inoperable, and unfortunately, also the patient passed away. Adrenal carcinoma is very aggressive, and it has a very poor prognosis. All right. Now, coming to the localization of ectopic ACTH syndrome. You know that there are many neuroendocrine tumors, or even some tumors like bronchial carcinoid, that can secrete ectopic ACTH. Okay, so here you can see a plain X-ray of the chest in PA view showing a suspicious lesion behind the apex of the heart. Here, let me revise the anatomy. This is this is the right clavicle, and this is the left clavicle. This is the right lung full of air, so this is why it appears black. This is the left lung full of air. This is why it appears black. This is the trachea, you see, it's filled with air, so, and it's central, so this is why it appears somewhat black in color. And this is the aortic knuckle. This is the cardiac waist. This is the right border of the heart made by the right atrium and left atrium as well. And this is the left border of the heart made by the left ventricle, and the apex, of course, made by the left ventricle. This is the right cupula of the diaphragm, and this is the left cupula of the diaphragm. And here the bronchial recesses are clear, meaning that there is no pleural effusion. But here you have a suspicious lesion behind the left the left cardiac shadow. Okay. Now, if you do a high definition CT scan of the thorax in axial cut, axial view, this is posterior, this is anterior, this is right, and this is left. And this is the thoracic vertebra. These are the ribs on the right side, which appear white because bone appears white on CT. CT uses X-ray, like the regular X-ray. And these are the ribs on the left side. Also, they appear white. This is the descending thoracic aorta. This is the right lung. It appears black because it's full of air. This is the left lung. It appears black because it is full of air. And this is the start of the cupula of the diaphragm, the right cupula of the diaphragm with the liver. And here, this structure is what? Who can tell me? In front of the descending thoracic aorta. What is this structure? Who can tell me? Who is good in anatomy? Huh? What is this structure? This is the esophagus. You see, it has a wall and it has it contains air inside and mucosal folds. And the white arrow points at this bronchial carcinoid, which appeared in the plain X-ray behind the cardiac shadow. See, so in high definition CT, it appears very clearly, right? Type. If you do, this is a sagittal reconstruction of high definition CT of the thorax. Here they have used intravenous contrast. How do we know? Because the lung field here that appeared black, totally black, here it appears mottled, black and white. Why? Because the bronchovascular markings, the vasculature of the lungs, has taken up the contrast, so it appeared white. And air in the lung appears black, so this is why it appears mottled like that. This is the front or the sternum. This is the back or the vertebrae. This is the heart. The heart appears excessively white because it's full of contrast, okay, IV contrast. And these are both cupula of the diaphragm. It's a dead lateral picture or a dead sagittal. They are superimposed on each other. This is why you cannot distinguish between right and left cupula. And the black arrow points at this lesion, the bronchial carcinoid, which lies in the lung but behind the heart. Is it clear? So here we have seen two modalities, plain X-ray, which didn't show very clearly the lesion, and then high definition CT in two cuts, the axial and the sagittal reconstruction. Okay, but then we have something called octreoscan. What is an octreoscan? Many neuroendocrine tumors, they were found to have also receptors for octreotide or somatostatin, right? Octreotide is actually the synthetic form of somatostatin. And so here they have labeled it with radioactive indium, and the radioactive indium labeled octreotide scintigraphy is called octreoscan. Here, actually, it can visualize the axial cuts, the sagittal cuts, as well as the coronal cuts. Okay. Here it shows two foci of increased uptake in the left hilum of the lung. So this means that this case was an ectopic ACTH syndrome caused by small cell carcinoma of the lung. They could visualize where the origin of the ectopic ACTH is. Okay. Of course, this octreoscan is not available here in Alexandria. There are some centers in Cairo only that do it, and it's very, very expensive as well. Okay, so you don't actually do it routinely. You just do it when you doubt or you want to locate a tumor that may be operable. Plus, you don't just do it for the sake of localization. It has to be also operable in order to be able to remove it, to cure the patient. Okay? Anything that is not clear? Is the imaging for Cushing syndrome clear? Huh?
Yes, doctor.
Yes, doctor.
Okay. Do you want to take a break, or shall we continue? What time is it now? It's 8:13. Do you want to take a 5 minutes break? Huh?
Yes, we can
Yes,
take a break, doctor.
Okay. Okay. So let me see how many you are. How many are you? Just 10. Okay. I expect the same number to come back, right? We'll come back like
Right,
at
doctor.
20 past 8. Okay?
Okay, doctor.
Okay.
Are we back? You hear me?
Yes, we can.
Can you still see my slides?
Yes, doctor.
Okay. They are in slideshow, right?
Yes, doctor.
Okay. Now let's shift to Addison's disease. Quite the opposite. The clinical features of primary adrenal insufficiency, because of course, like you have heard along the endocrinology course, we have primary adrenal insufficiency, where the problem is in the adrenal glands, and we have secondary adrenal insufficiency, where the problem lies in the pituitary gland. It can be isolated, but more commonly it is part of pan-hypopituitarism. Okay? So these are the clinical manifestations, the summation of the clinical manifestations of primary adrenal insufficiency. The patient has actually excessive skin pigmentation, not only skin pigmentation, but also buccal pigmentation, like I'm going to show you. The patient may complain of, the patient may be drowsy or even confused or even comatose. And if the patient has any scars, they will be pigmented. And women show loss of pubic hair, the muscle weakness, there is profound muscle weakness. The patient complains of anorexia, nausea, vomiting, abdominal pain, and hypotension with postural hypotension. This is very important. There is tachycardia and a reduced cardiac size, and there may be also vitiligo if the original cause is autoimmune adrenalitis, or there may be a scar of previous adrenalectomy, of course, bilateral adrenalectomy, if the cause is post-surgical, yani. And if it is part of Schmidt's syndrome, which is polyendocrine failure, there may be also a goiter with hypothyroidism, right? And of course, if it is also autoimmune adrenalitis, the cause of Addison's disease, there may be associated autoimmune hypothyroidism, right? And if you look at the fundus of the patient, you may also see papilledema, okay? So these are all the clinical manifestations in terms of symptoms and signs. But let me tell you the detailed symptoms. All patients complain of weakness, tiredness, and fatigue, all of them. All patients complain of anorexia, they have loss of appetite, but only 92% of patients have gastrointestinal symptoms in the form of nausea, in 86%, vomiting, 75%, constipation, 33%, abdominal pain in 31%, and diarrhea in 16%. Of course, there is salt craving in 16%. Salt craving, the patient wants to eat, to increase the salt intake in the diet. The patient, he or she, they want to eat a lot of salty food items, olives, green olives, black olives, salty cheese. We have this old cheese, Gibna Adima, and we have also Gibna Turkey. Okay, all of these are, they are very salty, or they can eat a lot of pickles with food, and they complain of postural dizziness in 12%. Why? Because they have postural hypotension. And the relevant signs are all patients have loss of weight. Okay. And 94% have hyperpigmentation. Again, why? Because here, due to the excess cortisol, the excess ACTH, the cortisol is low. So by the feedback mechanism, ACTH will be excessive, causing hyperpigmentation. And 88 to 94% have hypotension with a systolic blood pressure less than 110 millimeters mercury. 10 to 20% of patients have vitiligo, and only 5% have the auricular calcification. All right. So let me show you some pictures of some patients. These are the palms, you see, the palms and the fingers of a patient with primary adrenal insufficiency, showing hyperpigmented palm creases. If you look at your own palm creases, you will find they are pink, but here they are like brown in color, as well as hyperpigmented nail beds. You see the longitudinal dark lines in the nails compared to your own, okay? And here again, this is a Caucasian lady. She's, she used to be white in color, her skin, I mean. But now look at the knuckles in particular. The knuckles, they have turned brown in color because they became hyperpigmented, okay? And here, these are two other patients. This is to show you the hyperpigmentation of the creases of the palm and the hyperpigmented knuckles. And here you can see the hyperpigmented knuckles again. All right. And here you can see this is the elbow, the olecranon process. Over it, there is also hyperpigmentation over the olecranon process. So as a rule, this hyperpigmentation, you can detect it over areas of pressure areas, like the elbows, the knuckles, the lateral malleoli. If the patient tends to sit cross-legged on the floor, for example, on the knees, particularly in Muslims who tend to pray, من السجود يعني, okay? As well as in the hyperpigmentation, you can detect it also over the nipples. They become excessively dark in color in males and females, and over scars of previous operations. And in the buccal mucosa, here you can notice, you see the gums, above the upper incisors, they have this dark pigmented areas, you see. So this is hyperpigmented gums. And inside the buccal, the buccal mucosa, particularly near where the molars and the upper and lower molars compress the buccal mucosa, you see, it's very dark. So this means that if you have an edentulous patient who is not wearing a dental prosthesis, you will not be able to detect the hyperpigmented buccal mucosa because the pressure is lacking, okay? And here you can see there is hyperpigmentation where the upper incisors compress the lower lip, the inner aspect of the lower lip, hyperpigmentation of the inner aspect of the lower lip, okay? And this is vitiligo. You see, this is the normal skin color of this lady, and all of this is the vitelliginous patch. Okay. Of course, vitiligo is one of the autoimmune diseases that can affect the body. This can be encountered in autoimmune adrenalitis, leading to primary adrenal insufficiency. Okay. And this is to show you, this is a scar of surgery. It used to be pink or near the color of the normal skin, but then the patient, particularly if it's a female patient, she will come running because something cosmetic, you see. You see, doctor, I used to have this surgical scar. It became brown in color. It wasn't this color before, you see. Now, this is a very interesting picture. These are twins, identical twins, and one of them has Addison's disease. Which one do you expect? Who can tell me? This lady or this lady? Who can tell me? Huh? Huh? Can you still hear me?
The one on the right?
Yes, of course, the one on the right. Why? Because you see, this one appears very happy. She has this is the normal. This is not facial plethora. This is the normal complexion in Caucasians, right? But this lady, you see, she has lots of weight and she has hyperpigmented skin and hyperpigmented lips, and she looks really very miserable compared to this one. She can't even smile. Okay? Very good. So this one is the twin with Addison's disease. Now coming to anything that is not clear in the clinical picture, did you see an actual patient with Addison's disease in the ward?
Yes, doctor.
Okay, was it a male or a female patient?
A male patient.
And what signs did he have? What symptoms?
He had always a hypotension, hypoglycemia, and
Yes.
had skin hyperpigmentation.
Mm-hmm.
Always in his labs he always had hyponatremia and hyperkalemia.
Mm-hmm.
بس يعني
Okay. Okay. And did he have postural hypotension?
Yes. Yes.
Okay. Okay. Very good. Now, what was the cause of his Addison's? Were you able to detect it?
He was primary adrenal insufficiency due to autoimmune disease.
But he didn't have any vitiligo or any associated hypothyroidism, autoimmune. He didn't have.
No, he didn't have.
And he didn't have also any autoimmune, for example, pernicious anemia or celiac disease or any other myasthenia gravis, anything like that? Any other autoimmune diseases?
I don't remember, صراحة.
Okay. Okay, never mind. Okay, thank you very much. Okay, so coming to imaging in Addison's disease. You see, if mind you, the cause may be TB of the adrenal glands. In that case, usually the adrenal gland becomes fibrosed and calcified. So the calcifications are visualized on plain X-ray of the genitourinary tract, like here. This is an AP view, and here this is the renal angle. You see, this is the psoas, the psoas muscle shadow here and there, and here is the area of the right adrenal and the left adrenal. You see, they appear calcified. This is why they appear white in color, like bone. Okay, so fibrosis of adrenal glands occurs in TB, adrenalitis, and the adrenals can show calcifications in 50% of cases. Okay, now coming again to CT of the adrenal glands. This is a CT abdomen, axial cut, adrenal protocol showing. Now, let me revise the anatomy. This is the vertebra, this is the back, this is the front, this is the right side, this is the left side of the patient. So this is the vertebra, the right side, the ribs on the right side, the ribs on the left side. This is the abdominal aorta, and this is the right crus of the diaphragm. This is the left crus of the diaphragm. Here is the liver on the right. This is the spleen on the left. And here you can see, the white arrows point at these structures. It's exactly the same like bilateral adrenal hyperplasia, right? So in absence of any history or any clinical signs or any laboratory data, you cannot say just by looking at the imaging modality what the cause of the enlargement of the adrenal glands is, right? But this patient, we know the history. He or she, they presented with history of drowsiness, abdominal pain, vomiting, diarrhea, weakness, postural hypotension, tachycardia, and hyperpigmentation. So this is bilateral adrenal tuberculomas. Imagine, this is a very rare condition. The patient had tuberculomas, granulomas due to TB in both adrenal glands. And here they are not yet calcified, like in the first picture that I showed you, the one of the plain X-ray. This is how it looks like, okay? Okay? Anything difficult? So let's look at this picture. This is another CT, abdomen, axial cut, adrenal protocol showing. This is the vertebra. These are the ribs on the right side, the ribs on the left side. This is the abdominal aorta. This is the right crus of the diaphragm. This is the left crus of the diaphragm. And here are the loops of intestine filled with gastrographene, white, alternating with air that floats on top of the dye. And these arrows point at these structures. This is the left kidney and this is the spleen. What are these? These are adrenal glands, okay? They are enlarged, but why? Imagine here, by the way, they didn't give any intravenous contrast. You see, the aorta is gray. It's not white in color. But who can tell me what this white speck is in the aorta? You see, there is a white speck here. Can you see it? In the anterior wall. What is this? Who can tell me? Who can tell me what is this? A calcified atheromatous plaque. This one. Okay? But why are the adrenals very bright like that? It turns out actually that this patient had history of pulmonary embolism and he was receiving oral anticoagulant therapy, but he wasn't properly managed by checking his INR at the time of warfarin. Nowadays, if you give the patient the recent direct-acting oral anticoagulants, no need to check the INR. But this patient was at the time of warfarin, so he didn't follow up the INR closely, so he developed bilateral adrenal hemorrhage from anticoagulant therapy. Very unlucky, actually, bilateral adrenal hemorrhage, and he presented with Addisonian crisis. Very interesting case. Of course, very rare, and you won't be able to see such a case. Let's see. This is another CT abdomen. Axial cut at the adrenal, at the level of the adrenal glands, with oral contrast only. No intravenous contrast is given, showing the following. This is the vertebra, the ribs on the right side, the ribs on the left side. This is the abdominal aorta. It appears dark in color because no intravenous contrast was given. This is the right crus of the diaphragm. This is the left crus of the diaphragm. And this is the upper pole of the right kidney. And this is this globular structure appears with a white rim of calcification. And this is the left adrenal gland. It appears also globular in structure with a white rim of calcification at the periphery. And this is the spleen, okay? So this is a very rare condition as well. This is histoplasmosis, a fungal infection with bilateral subcapsular calcification of the adrenal glands. And the patient presented with a primary adrenal insufficiency. You see, very rare as well. I have never seen such a case. Now, this is another very interesting case. This is a CT on the adrenal gland, axial cut at the level of the adrenals or the adrenal protocol, showing this is posterior, anterior, right, left, the vertebra, the ribs on the right side, the ribs on the left side, the liver, full of these grayish structures. I will ask you in a minute what these are. And this is the spleen. And here, this is the abdominal aorta. Here, they didn't administer intravenous contrast, only oral contrast, okay, visualizing the loops of intestine. This is the right crus of the diaphragm. This is the left crus of the diaphragm. What is this? And what is this? All of this. It turns out this patient had malignant melanoma of the skin, metastasizing to the liver, as well as to both adrenal glands, and the patient presented with Addison's disease. A very rare presentation again, but you have to put in mind, okay? Anything not clear so far? Any problems? Okay. Any problems with the Addison's disease?
Understood, doctor.
Okay. Let's shift to pheochromocytoma. Now the clinical
دكتور
presentation.
معلش
Yes,
دكتور؟
tell me. Yes.
هو الأديسون بيبقى اللي ناقص الكورتيزول بس ولا المينرالو كورتيكويد؟
In primary adrenal insufficiency, both are deficient, both. cortisol and mineralocorticoids. Cortisol is one of the glucocorticoids, the main, glucocorticoid, and mineralocorticoids are like aldosterone. So in primary adrenal insufficiency, both of them are missing. So when replacing, you have to replace both cortisol as well as fludrocortisone. The synthetic mineralocorticoid. Okay, but in secondary hypocorticism, only cortisol is missing. Okay, this is the important difference. Is it clear? Is it clear?
Clear يا
Okay.
دكتور.
Fine. Now back to pheochromocytoma. The clinical presentation of pheochromocytoma usually this is the usual, but actually nowadays we can see a lot of unusual presentations. Yeah, we have a rule of 10, meaning that 10% are extra adrenal. So if you doubt that your patient has pheochromocytoma and you do imaging on the adrenals and you don't find anything, you have to look for pheochromocytoma tissue or neuroendocrine tissue elsewhere, extra adrenal. 10% occur in children. Actually, I have seen a patient, a male, a boy, who was 10 years old, a very long time ago. He presented with severe hypertension in bouts. The blood pressure used to reach as high as 180 by 110. And during the fit, or during the spell, the paroxysm, the patient appeared to be shocked. He was very pale, and he had tremors, and the pulse was very thready, in spite of the fact that the blood pressure during the spell was very high. Why is that? Because he had the severe vasoconstriction and he was dehydrated. You see, the low plasma volume is the cause of causing a shock-like state during the pheochromocytoma spell. This is why before transferring a patient for surgery, a patient with pheochromocytoma, to do surgery, you have to hydrate the patient well. You have to ensure that the plasma volume is adequate in order for the patient not to develop hypotension in the post-operative period. All right? And 10% of pheochromocytomas are multiple or bilateral. 10% recur after surgical removal. Actually, during my residency, I have seen this. This was the first case of pheochromocytoma I have ever seen in my life. She was a nurse. She used to work at the Miri Hospital. She was in her 40s. She had developed a pheochromocytoma, but for some reason she went to Mansoura Hospital to have her pheochromocytoma excised. And then several years later, it recurred. So 10% recur after surgical removal. Actually, when she came to see us, she had this, we wanted to show the house officers how the pheochromocytoma spell looks like, or the paroxysm looks like. So her spell was provoked just by palpating her abdomen. Imagine, when we palpated her abdomen, although nothing was palpable, but just increasing the intra-abdominal pressure by palpation brought about the pheochromocytoma spell. Okay? 10% of pheochromocytomas are malignant, 10% are familial, and here this is very important to take the family history from a patient with pheochromocytoma. 10% of benign sporadic adrenal pheochromocytomas are found as adrenal incidentalomas, like the patient who was presented a couple of weeks ago at the scientific meeting. Remember him? He was sent to urology department to have his pheochromocytoma excised. Any news about him? Any news about him, Dr. Sameh or Dr. Nadine? Did you follow the patient up?
لا بصراحة يا دكتور ما عنديش معلومة وصل لإيه.
طيب you have to follow up the patient because it's very important to know what happened to him huh? And also you have to follow up the histopathology whenever they get the result of the histopathology, or you can do that by going to the secretary of the pathology department, but you have to know when the specimen was sent, what date, to get the report, or to know what the histopathology was, benign, malignant, what it was. Okay, please. This is very important. Okay. Now, the clinical presentation of pheochromocytoma is varied. It can be spell related, يعني related to the paroxysm. Okay. During the spell, the patient feels anxious and he or she they have fear of impending death. يقول لك روحي هتطلع كأن روحي هتطلع. They are diaphoretic. They sweat a lot. They have excessive sweating. They have dyspnea. They have epigastric and chest pain, headache, hypertension, like the boy I told you about, nausea and vomiting, pallor. Pallor, don't tell me flushing. Why? Because there is vasoconstriction. A palpitation, meaning forceful heartbeat, and tremors. But in between the spells, there may be also chronic presentation of pheochromocytoma. It may have some similarities to the spell-related symptoms or signs. For instance, anxiety and fear of impending death is also present in the chronic presentation. Cold hands and feet due to the persistent vasoconstriction, congestive heart failure, or dilated or hypertrophic cardiomyopathy, constipation, diaphoresis, and dyspnea, they are common as well, and epigastric and chest pain. Ectopic hormone secretion dependent symptoms like CRH or ACTH, growth hormone, releasing hormone, PTH, releasing peptide, related peptide, and VIP. But these are actually very rare. Fatigue and fever, right? And general increase in sweating, although the patient is not hyperthyroid. Grade 2 to 4 retinopathy. I will show you the picture. The child, the 10-year-old boy I have seen before had grade 4 retinopathy, like I'm going to show you in the picture in a while. Headache, hyperglycemia. Pheochromocytoma is one of the important causes of secondary diabetes. Okay, hypertension, again, in between attacks. The patient may show spells of severe hypertension, but in between the spells, the patient may also hypertensive and his blood pressure is not controlled on several antihypertensive medications. I have seen a patient once, he was like in his 50s. He used to take 5 antihypertensive medications in the full dose, but his blood pressure was still high. Okay? So he was diagnosed as having pheochromocytoma after we did all the tests. Nausea and vomiting, again, orthostatic hypotension, painless hematuria, in particularly if the patient has a urinary bladder paraganglioma. This is neuroendocrine tissue present inside the urinary bladder. In that case, we don't call it pheochromocytoma, but you call it paraganglioma. Pallor, again, pallor, forceful heartbeat leading to palpitations, tremor, and weight loss. And this is the grade 4 hypertensive retinopathy I was telling you about. The patient who was 10 years old, only 10 years old, because he had severe hypertension, in addition to the spells of even bouts of more higher blood pressure values. He had papilledema and he had cotton wool spots. He had hard exudates, these yellow spots, and he had flame-shaped hemorrhages. This looked exactly like, this picture looks exactly like the fundus of the 10-year-old boy I was telling you about. Okay? Now, the typical spell is actually, it means there are episodic symptoms which occur in spells or paroxysms, and they can be extremely variable in presentation, but typically all of them include a forceful heartbeat, pallor, again, not flushing, pallor, tremor, headache, and diaphoresis. So the spell may start with a sensation of a rush in the chest, يقول لك حاسس هبو كده طالع على صدري, and a sense of shortness of breath, dyspnea, followed by a pounding heartbeat, very strong and rapid heartbeat that typically progresses to a throbbing headache. And here you have to be able to distinguish it from migraine headache, right? Peripheral vasoconstriction with a spell results in cold hands and feet and facial pallor. An increased sense of body heat and sweating are common symptoms that occur towards the end of the spell. Now, our patient, the patient that we saw, the one with adrenal incidentaloма, didn't have any spells, right? Correct me if I'm wrong, Dr. Sama and Dr. Nadine. He didn't have any spells, right?
لا يا دكتور.
Okay. Okay. Now, the typical spells may be either spontaneous or they are precipitated by postural change, anxiety, medications like metoclopramide, or even anesthetic agents. This is why you have to properly prepare your pheochromocytoma preoperatively, because while once they start to administer anesthetic agents to the patient, he or she, they will develop a paroxysm. Exercise can also precipitate a paroxysm, and maneuvers that increase intra-abdominal pressure, like change in position, lifting, defecation, exercise, colonoscopy, pregnancy, trauma. And the patient I told you about, the one with recurrent pheochromocytoma, this nurse, just palpating her abdomen, precipitated a spell. Okay? So always remember that. And spells may occur multiple times daily or as infrequently as once monthly. You can never tell. And the typical duration of a pheochromocytoma spell is 15 to 20 minutes, but it may be much shorter or it may last several hours. However, the clinician must recognize that most patients with spells do not have pheochromocytoma. This is important because there are many other conditions that are similar to pheochromocytoma spells, but they are not pheochromocytoma. It is not very common. Okay? Anything so far that is not clear? Anything that is not clear? Now coming to imaging. Okay, imaging in pheochromocytoma. Again, this is an axial CT. Again, an axial CT with contrast, both intravenous and oral, because here you see the abdominal aorta is appears bright and the portal tracts appear Bordeaux bright. They have taken the dye, and here the loops of intestine have are filled with gastrografin. Okay, so here let me show you the anatomy. This is a CT abdomen, axial cut, adrenal protocol with intravenous and oral contrast, showing this is posterior, this is the vertebra, anterior, this is the right side, the ribs on the right side, the liver with the portal tracts, and these are the ribs on the left side, this is the spleen, and this is a nice, very nice picture. See, this is the abdominal aorta, and this is the celiac trunk. See, it appears like the nozzle of an elephant, the celiac trunk, and this is the right crus of the diaphragm. This is the remnant of the left crus of the diaphragm. This is the right kidney. This is the right adrenal. You see, very thin compared to the right crus. All of this is a very large left adrenal mass with a heterogeneous structure, partially vascular and partially nephrotic left adrenal tube. Turns out to be a pheochromocytoma. Okay. Now this is the MRI. Remember some of you asked me how can I differentiate between the CT and the MRI? The CT appears, the picture appears somewhat clear, right? But here in the MRI, it appears as if it's blurred. Okay. And then, of course, we have a T1 weighted image and a T2 weighted image. How can we tell? Just by looking, this is a T1 weighted MRI of the adrenal gland in pheochromocytoma. Again, it's cut axially, right? Transverse like that. This is posterior, this is anterior, this is right, this is left, and this is the liver, this is the gallbladder. And here you can see the vertebra. Here you can see, if you look closely, the spinal cord, and around it the CSF appears black. So this is why we say it is a T1 weighted image. Okay, this is the abdominal aorta, the right crus of the diaphragm appears black, the left crus of the diaphragm, and here this is the left kidney, the left adrenal, the spleen, and all of this is the pheochromocytoma. Okay, and it appears heterogeneous, you see. And the size is relatively big, 3.3 by 3.5 by 4.5. And if you do the T2 weighted image, it appears like that, you see. Here you see what is striking, the CSF. The CSF appeared white, you see. So this is why we say it is a T2 weighted MRI of the adrenal gland, showing the same structures again. This is the vertebra, this is the abdominal aorta, the right cross, the left kidney, the spleen, the liver, the portal tracts, the gallbladder, and here you can see the arrow pointing at the adrenal, the right adrenal gland. Here it's again heterogeneous, and it has an increased signal intensity on T2 weighted images. Why do we say it is a T2 weighted image? Because here the CSF around the spinal cord appears white. Anything that is not clear in this image? Any problems? Any problems so far?
It's clear, doctor.
Okay, now in pheochromocytoma, the scintigraphy in pheochromocytoma using radioactive iodine labeled MIBG, methiodobenzoguanidine scan, right? Usually here it is clear because this is the anterior view and this is the posterior view. Here, then a radioactive iodine MIBG whole body scan shows a large focus of increased radiotracer uptake in the left upper abdomen, but this is a clear-cut case. Usually there are many other cases that are not visualized in, I mean, you cannot localize where the pheochromocytoma tissue is. And maybe it can appear here in the stellate ganglion or here in the abdomen, in the organ of Zuckerkandel, or inside the urinary bladder if it is a paraganglioma. So this is the best way to visualize an extra adrenal pheochromocytoma. This technique is not done to visualize or to locate an adrenal pheochromocytoma. Okay, it's usually reserved because it's very expensive, and sometimes also you cannot find the tracer easily, and it's very, very expensive. Okay, so it's not done routinely. It's done only in cases where you're not able to locate the pheochromocytoma tissue. Okay, and this is an radioactive labeled MIBG SPECT fusion CT scan. Here they use CT to visualize the anatomy in axial, in coronal, and in sagittal reconstruction. And here you can see the SPECT, which reveals the physiology or the function of the tumor here in axial and coronal and sagittal as well. And if you fuse both pictures together, you can have a clearer fusion scan in order to be able to locate where exactly the tumor is. But again, here, this is a typical site. I mean, here the tumor is, the pheochromocytoma is in the area of the left adrenal gland. So it shouldn't be problematic localizing this tumor. But it's resorted to because it's really very, very expensive. It's resorted to in localization of extra adrenal pheochromocytomas. Anything that is not clear? Any problems? Okay, so now let's go to the last thing we're going to discuss today, Conn's disease. The clinical picture, actually, many patients are asymptomatic, but they may have features of sodium retention or potassium loss. And as you know, sodium retention may cause edema, while hypokalemia can cause muscle weakness and even paralysis, especially in Chinese persons. And hypokalemia can also present with polyuria, secondary to renal tubular damage, which produces nephrogenic diabetes insipidus, and occasionally tetany is also produced because of associated metabolic alkalosis with low ionized calcium. All right, so this is the clinical picture. Now, coming to the investigations. Biochemical investigations are done first. Here you check the plasma electrolytes, and they may show hypokalemia and elevated bicarb level. Plasma sodium is usually towards the upper end of normal range in primary mineralocorticoid excess, and it is characteristically low in secondary hyperaldosteronism because low plasma volume stimulates antidiuretic hormone release, and high angiotensin II levels stimulate thirst. Okay, And plasma, as regards the plasma renin activity and aldosterone level, if renin is low and aldosterone levels are high, then Conn's adenoma can be differentiated from bilateral adrenal hyperplasia by doing the tests of aldosterone response to angiotensin II. In Conn's adenoma, aldosterone does not rise on standing or with furosemide administration. Okay? So in Conn's adenoma, renin is low, aldosterone is high, and aldosterone does not rise on standing or it does not rising on administering furosemide. Okay? In the rare circumstance when renin and aldosterone are both low, you need to test further and you measure urinary cortisol and its metabolites as well as 11-deoxycorticosterone. Okay? And mind you that almost all antihypertensive drugs interfere with these hormones. Beta blockers inhibit, while thiazide diuretics stimulate renin secretion. So these should be stopped for at least 6 weeks before doing these tests. If this is not possible, then you can use antihypertensives which have minimal effects on the renin-angiotensin system like calcium antagonists and alpha blockers. Okay? Now coming to localization, so first we do the biochemistry and then in order to locate where the tumor is, of course the only cause of primary hyperaldosteronism, which is usually treated by surgery, is Conn's adenoma, which is in the adrenal gland. So abdominal CT is often the only test required to localize the tumor. Okay? But it is important to recognize that functional adrenal, non-functioning adrenal adenomas are present in about 20% of patients with essential hypertension, and adrenal CT should only be performed when the biochemistry supports the diagnosis of an adrenal tumor in order not to have a misdiagnosis, okay? But if the scan is inconclusive, then adrenal vein catheterization should be done with measurement of aldosterone and cortisol to confirm positioning of the catheters, or radioactive iodo-norcholesterol scanning may be helpful. This is another scintigraphy using radioactive labeled iodine cholesterol, iodinated cholesterol. Why cholesterol? Because as you all know that cholesterol is the building block of aldosterone and all the adrenal hormones, adrenal cortical hormones. Okay? Anything so far that is not clear? So coming to imaging in Conn's disease, this is again a CT abdomen, axial cut at the level of the adrenal glands, showing this is posterior, this is anterior, this is right, this is left, the vertebra, the ribs on the right side, the ribs on the left side, and this is the liver, this is the spleen, this is the abdominal aorta. And here they didn't administer any intravenous contrast, but they have given oral contrast, filling the loops of intestine. This is the right kidney already. Here there is the remaining part of the right cross is visible here. The left cross, just a very tiny area visible, the right kidney, the left kidney. Okay, and here you can see the white arrow pointing at this left adrenal adenoma, which is consistent with the Conn's syndrome. Okay, and here this is the radioactive iodine labeled norcholesterol scan, showing tracer uptake, radioactive tracer uptake in the left adrenal adenoma. The right is not visualized. So the radioactive tracer is only taken up by the adenoma, but not by the normal, or here in that case, the other suppressed adrenal gland. Okay. And this is the surgical specimen of the tumor. You can see it is canary yellow in color because of the high intracellular lipid content. So this is a case of Conn's adenoma. Okay. Actually, I have seen a Libyan case, a Libyan patient, a long time ago. She came from Libya. She had, all she complained of was headache. She didn't have any muscle weakness. She didn't have any ankle edema. She didn't have any other complaint except headache. And she went to see a nephrologist. all right, professor of nephrology. The professor of nephrology ordered all the renal function tests and the electrolytes, and she found the patient to be severely hypokalemic. Her serum potassium was 1.9 milliequivalent per liter, 1.9, very low. And so she referred the patient to me. The patient was taking several antihypertensive drugs, but the blood pressure was still not controlled. She was like 150 over 100. Okay, so we did the investigations. I did the renin, the aldosterone, and so on. And so I discovered the patient had a primary aldosterone secreting adrenal adenoma. And it was removed back then. There was still, the surgeons didn't master the technique of laparoscopic adrenalectomy. So she had an open adrenalectomy. They opened her from the back, an open adrenalectomy to remove the adrenal. After the adrenalectomy, in the first few post-operative days, she developed hypoaldosteronism. So the potassium level, instead of being low, it became higher than normal, but the blood pressure returned to normal without any antihypertensive medications. And she returned safely back home, but she never came back for follow-up. Okay, this is the only case of Conn syndrome I have seen. Only one case from 1991 till 2025. Okay. Any questions so far? Now I have put in the chat the link for the actually nobody is in the lobby. Who wrote Dr. Samat? Nobody is waiting for my permission to attend. Only you are there. So I've put the link. I will put it again for you to answer the survey, please, about today's session. And there is still some time. If you like, I can give you some multiple choice questions to solve. You see, somebody has responded already. Let me see how many you are. You are 8, right? You're 7. So I need 7 responses, please. I need 7 responses. Do you like to have some MCQs on Cushing and Addison? If you like. If you don't like, خلاص, we'll call it a day. Could you access the link of the survey? Huh? Could you access the link? Can you still hear me? Am I talking to myself?
Yes, doctor. Yes.
We can hear you, Edward.
Okay, type. يلا. 2 responses. Okay. يلا. يلا. 5 more. 5 more to go. 5 more to go. Would you like to have some questions on some cases or is it enough for you today? Yeah. Okay. Yeah, 4 more to go. 4 more students to go.
يا ريت يا دكتور لو في أسئلة هيبقى كويس.
طيب اوكي. مين دكتورة سماء اللي بتقول ولا دكتورة مي؟
لا أنا سماء.
طيب دكتورة سماء. Okay. The rest of you, if you I didn't hear your opinion. I didn't hear your opinion.
دكتور معلش فين اللينك اللي حضرتك عايزانا نعمل فيه
in the chat of Microsoft Teams. The chat of Microsoft Teams. Can you see it? The chat of Microsoft Teams. Did you find it, Dr. Amay? Huh?
أيوة يا دكتور أيوة.
Okay. So let me just wait until all of you have finished the survey and then I'm going to show you the questions. Okay. Fine. Make it quick, but we don't have all night. How many remaining? Yalla, two more missing. Two more missing. Yalla, two more to go. I'm going to read out the survey results to you, and then we're going to solve the questions, okay? Yalla, the two missing students, could you locate where the link of the survey is? Huh? Why don't you answer? And it's very odd that you don't answer. Yalla, if you don't answer me, no questions, خلاص. If you don't answer, no questions, because the questions you have to answer. So there is no point in showing you the questions when you are keeping still. You're keeping quiet. Huh?
احنا موجودين يا دكتور، موجودين.
موجودين بس ساكتين يعني. ها؟
ما هو
دكتورة
هم اكيد بيملوا السيرفي، مش عارفين يفتحوا المايك،
لا،
هيخلصوا
ما دكتورة مي فاتحة الميكروفون اهي.
انا
دكتورة
خلصت
مي
خلاص.
فاتحة. خلصتي؟ طيب يلا، فاضل حد كمان. Somebody is missing. One student is still missing. طيب okay, let me read the answers to you. The timing of the session was appropriate. 83.3% strongly agree, 16.7% agree. The duration of the session was appropriate, 66.7% strongly agree, 16.7% agree, and 16.7%, this is only one, is neutral. The session was well organized, 66.7% strongly agree, 33.3% agree. The content of the session was very clear, 66.7% strongly agree, 33.3% agree. The instructor was well prepared. All of you strongly agree. There was adequate time for asking questions. 66.7% strongly agree. 33.3% agree. What did you like most about today's session? Adequate imaging investigations to understand identification of normal and disease conditions. Informative imaging modalities, imaging, many images for illustrations. It was to the point, covering all topics. What would you like to change in this session? Fully satisfied? Nothing. Thank you very much. You're most welcome. Nothing. It is very good. Okay. Thank you very much. And I'm really very angry at the one student who didn't take the time to fill out the survey. Let me share the questions with you. Can you see the slides? Can you see the slides? Okay.
Yes, doctor.
So here we have a 35-year-old woman who presents with weight gain, purple stria on her abdomen and facial rounding. Okay. Laboratory findings reveal elevated 24-hour urinary free cortisol, elevated midnight salivary cortisol, and unsuppressed morning cortisol after a low-dose dexamethasone suppression test, and plasma ACTH is undetectable. Okay? What is the most likely diagnosis? Cushing's disease, adrenal adenoma, ectopic ACTH secretion, pseudo-Cushing syndrome. Who would like to answer? Who would like to answer? Dr. Hiba, go ahead.
Adrenal adenoma.
Type. Do anybody else, does anybody else have another suggestion? Okay, so it's adrenal adenoma. Very good. Type. The learning points here. Though ACTH and high cortisol indicate ACTH independent Cushing syndrome, what I was telling you about, most commonly caused by an adrenal adenoma, while pseudo-Cushing, when you always read this word written like that, P-S-E-U-D-O, it means false. False Cushing and ectopic ACTH secretion have normal or elevated ACTH. All right? The second case, a 50-year-old man presents with muscle weakness, central obesity, and easy bruising. Laboratory tests show elevated 24-hour urinary free cortisol, elevated plasma ACTH, high-dose dexamethasone suppression test shows partial suppression of cortisol. All right? What is the most likely source of ACTH? Pituitary adenoma, small cell lung carcinoma, adrenal carcinoma, pseudo-Cushing syndrome. Would like to answer? Who would like to answer?
Pituitary adenoma?
Exactly. Pituitary adenoma. Very good. Okay. So partial suppression with high-dose dexamethasone suggests Cushing's disease and ACTH producing pituitary adenoma. Ectopic ACTH secretion typically does not suppress. Okay? Very good. A 60-year-old man with a history of smoking presents with weight loss, hypertension, and hyperpigmentation. Laboratory findings show high cortisol levels, elevated ACTH, which does not suppress with dexamethasone at any dose. Chest imaging reveals a long mass. What is the most likely diagnosis? Ectopic ACTH secretion from lung carcinoma, Cushing's disease, adrenal adenoma, pseudo-Cushing syndrome. Would like to answer?
Ectopic ACTH secretion from lung carcinoma.
Yes, exactly. Very good. Okay, so the lack of cortisol suppression and the lung mass strongly suggest ectopic ACTH secretion, often due to small cell lung carcinoma, like I showed you in the imaging. 42-year-old woman with Cushing's disease undergoes transsphenoidal surgery. Post-operatively, she develops fatigue, nausea, and hypotension. What is the most likely cause? Persistent pituitary tumor, adrenal insufficiency, ectopic ACTH secretion, surgical site infection. Would like to
Adrenal
answer?
insufficiency.
Yes, she had an ACTH secreting pituitary adenoma, which was removed, and post-operatively, she developed adrenal insufficiency. Very good. So chronic cortisol excess suppresses the hypothalamic pituitary adrenal axis, leading to secondary adrenal insufficiency after tumor removal. Here it is secondary, not primary. Okay, so here, whoever asked me, you will not be able to find mineralocorticoid deficiency. Okay, only glucocorticoid deficiency. A 28-year-old woman presents with acne, hirsutism, and irregular periods. She has central obesity and a dorso-cervical fat pad or buffalo hump. Okay, low-dose dexamethasone suppression test reveals high morning cortisol levels and ACTH is within the reference range. What is the next best step in diagnosis? 24-hour urinary free cortisol, midnight salivary cortisol, high-dose dexamethasone suppression test, CT scan of the adrenal glands. Who would like to answer? Who would like to answer?
High-dose dexamethasone?
Yes, exactly. High-dose dexamethasone suppression test. So here the high-dose dexamethasone suppression test helps differentiate between pituitary and ectopic ACTH production. Imaging is premature without confirming the ACTH source, because otherwise will you check for an ectopic ACTH source or will you do an MRI on the pituitary? Okay, so you won't be able to know which imaging procedure to perform. A 65-year-old man with known ectopic ACTH secretion presents with severe muscle weakness and hypokalemia. What is the most appropriate immediate treatment? Surgical resection of the ACTH secreting tumor, spironolactone, potassium replacement, and ketoconazole, low-dose dexamethasone. Who will like to answer? Would like to answer?
سبايرينولاكتون.
Why?
عشان ممكن يكون ان هو كونز ديزيز severe muscle weakness مع ال severe
you didn't read the head. 65-year-old man with known ectopic ACTH secretion. Here he gave you already the diagnosis. He has known ectopic ACTH secretion, but he presents with severe muscle weakness and hypokalemia. So which of these is the appropriate immediate treatment?
أعتقد هنديله potassium replacement ketoconazole.
Exactly, because potassium replacement to replace the severe hypokalemia, and ketoconazole is an antifungal, but it acts like a medical adrenalectomy. Here you want to reduce the level of cortisol level before you send him to do surgery if operable, or you can keep him on ketoconazole for medical adrenalectomy to check his to keep his cortisol level normal. Okay. So here, hypokalemia and severe hypercortisolism require immediate cortisol suppression by ketoconazole and potassium correction. Surgery is delayed in unstable patients. And even some patients with ectopic ACTH secretion, they have a tumor that secretes ACTH ectopically that is inoperable. So you're not able to operate on them, okay, to remove the source of excess ACTH. A 55-year-old woman with Cushing syndrome presents with psychiatric symptoms, including depression and irritability. Here, he gave you the diagnosis, Cushing syndrome, okay? But she has psychiatric symptoms, including depression and irritability. What is the pathophysiologic mechanism behind these symptoms? ACTH directly affecting the central nervous system, cortisol-induced changes in brain structure and function, hypothalamic inflammation, increased aldosterone levels. Would like to answer?
Cortisol-induced
I
changes.
think cortisol induced.
Yes, exactly. Cortisol-induced changes in brain structure and function. Actually, a long time ago, I have seen Bordeaux a Cushing's syndrome, a Cushing's disease patient. She had her tumor removed, but somehow I don't know what happened. It recurred sometime later because she had chronic high cortisol levels. Actually, when they did, she was in her 30s. She was young, yeah. When they did an MRI on the sella turcica, we could see she had brain atrophy. Not, yani she had a problem still in the pituitary, but what was striking that in spite of her young age, she still had brain atrophy due to the persistently high cortisol level. So excess cortisol can cause hippocampal atrophy and alterations in neurotransmitter function, leading to psychiatric symptoms. Okay. A 40-year-old man presents with central obesity and easy bruising. Laboratory findings show low ACTH, elevated cortisol that is not suppressible with dexamethasone. Imaging reveals a 3 centimeter adrenal mass. What is the most likely etiology? Adrenal adenoma, adrenal carcinoma, Cushing's disease, ectopic ACTH secretion. Would like to answer? Would like to answer? Can you still hear me?
يا دكتور معلش ممكن السؤال تاني من الأول؟
What is the most likely etiology? Adrenal من الأول من الحالة يعني the case. طيب. A 40-year-old man presents with central obesity and easy bruising, Cushing. Okay. Laboratory findings show low ACTH, elevated cortisol that is not suppressible with dexamethasone. Imaging reveals a 3 centimeter adrenal mass. What is the most likely etiology? Adrenal adenoma, adrenal carcinoma, Cushing's disease, ectopic ACTH secretion. Very obvious.
Adrenal adenoma.
Yes, exactly. Adrenal adenoma, very easy. This is a very easy case. An adrenal mass with ACTH independent hypercortisolism is consistent with an adrenal adenoma. Adrenal carcinoma would usually present with more aggressive features, right? A 36-year-old woman presents with fatigue, obesity, and hyperglycemia. Laboratory results show suppressed ACTH and elevated cortisol. Imaging reveals bilateral adrenal hyperplasia. Bilateral adrenal hyperplasia. What is the most likely diagnosis? Primary pigmented nodular adrenocortical disease, Cushing's disease, adrenal carcinoma, ectopic ACTH secretion.
Primary pigmented nodular.
Yes, exactly. Bilateral adrenal hyperplasia with ACTH independent hypercortisolism suggests primary pigmented nodular adrenocortical disease, often part of Carney's complex. Okay. And the last case here, a 58-year-old man is evaluated for persistent hypercortisolism after bilateral adrenalectomy for Cushing syndrome. He has skin hyperpigmentation. Laboratory findings reveal very high ACTH levels. What is the most likely diagnosis? Addison's disease, Nelson syndrome, adrenal carcinoma, recurrence, ectopic ACTH secretion. Who would like to answer?
Ectopic ACTH secretion.
No. Nelson syndrome.
Carcinoma recurrent.
No, Nelson. What is Nelson syndrome? Nelson syndrome, here, you have to read the case very carefully. You see, he had persistent hypercortisolism, okay? So they couldn't do anything except bilateral adrenalectomy, okay? Yani they removed both adrenal glands. After some time, he had hyperpigmentation and they discovered very high ACTH levels. So it is Nelson syndrome. What is Nelson syndrome? He had a pituitary ectopic, a pituitary ACTH secreting microadenoma, but it wasn't visualized. We saw a case like that before. Her name was Amina. Mrs. Amina came from Mansoura. Okay, so she had very white skin and she was very beautiful, like French people, yeah. So she was married and she had children. She developed Cushing syndrome. So she had truncal obesity. She developed secondary diabetes, secondary hypertension. She had severe myopathy. And she came to see us. Okay, so we started doing the investigations. The screening test was positive. Both tests were positive for Cushing syndrome. So we did the high dose dexamethasone suppression test. It was suppressible. So this means she has what? She has Cushing's disease. Okay. Back then, she came to see us like in the end of 1980s, 89, 1990, like that. Back then, we didn't have MRI yet in Egypt. So we did a CT on the pituitary. It revealed nothing. So we consulted the colleagues at the neurosurgery department. They refused to do surgery because back then also they went in blindly. They didn't have any operating microscope. They didn't have any operating endoscope, nothing. They went in blindly. So imagine they are going in blindly to explore for a non-existing lesion. So they refused. The lesion wasn't visualized on CT. So they refused to do the surgery type. So we sought advice at the oncology department. Our colleagues at the oncology department again refused to do radiotherapy because no lesion was visible in the CT. We told them, but it is a pituitary adenoma because the biochemical tests show that. They are not convinced. They want to see something, right? So the last resort was what we consulted our colleagues at the urology department, okay? And we agreed that this patient should have bilateral adrenalectomy. So they did a right adrenalectomy on one occasion, and 2 months later, they did the left adrenalectomy. Okay. Of course, the patient was placed on replacement therapy because she has no adrenal glands. Okay. And after several months, she came back for follow-up. She was miserable. First of all, we didn't recognize her. Remember, she was white in color. Now, when she came to see us, she was very black in color, as if she came from Africa. So what happened to her? And the Cushing's manifestation were even worse. Don't ask me how. She doesn't have any adrenal tissue. We measured the ACTH. It was even higher than before. And now we repeated the CT on the adrenals. Now there was a visible adrenal mass. Okay. So we went to consult the colleagues at the neurosurgery department. Now they agreed to have a pituitary surgery. What happened to her is that she developed Nelson syndrome after having had bilateral adrenalectomy. So Nelson syndrome occurs when there is a non-visualized microadenoma, pituitary microadenoma, which is not treated by radiotherapy, and then you treat the patient with bilateral adrenalectomy. It occurs in 20% of such cases, okay? So it happens to Mrs. Amina. And unfortunately, she became worse. The blood pressure wasn't controlled, the blood glucose wasn't controlled, and the muscle weakness was even worse than before, and her husband even divorced her. Yeah? when she came to see us with Cushing's disease, her husband already had married another lady. But now, after she developed Nelson syndrome, he divorced her altogether. So she was, yani, her life was ruined socially and medically as well. Okay. Yani fortunately nowadays we don't see such cases any longer, because we have MRI, which can visualize the pituitary lesion very well. If you don't see it on 1.5 Tesla, you can request a 3 Tesla MRI on the pituitary to visualize even better, and so on. Okay? Anything that is not clear?
Yes,
So
doctor,
here,
the source of cortisol at this level.
no, it's not the
What-
cortisol. It's not the cortisol. She doesn't have any adrenal tissue. It's the ACTH. So I don't know. I don't know what happened, but actually, she developed Nelson syndrome, and she had excessive ACTH. So maybe the excessive ACTH is the culprit that led to deterioration of her condition, in spite of absence of adrenal tissue. I have no explanation for that. But this is what we saw, yani. So Nelson syndrome results from pituitary tumor enlargement and excessive ACTH secretion after bilateral adrenalectomy for Cushing syndrome. Okay, actually for Cushing's disease it should be, not syndrome. All right. So this is you have. Do you want some more questions, or are you just tired? Are you tired already? Huh?
لا عادي يا دكتور، ممكن نشوف أسئلة كمان.
طيب شوف أسئلة كمان. طيب. Let me.
We could have more.
Sorry? Are you
We could
saying
have more.
Okay, I will show you another. Let me share my slides with you. Are the questions difficult? Huh? Are they difficult? You have to pay close attention to what is being said, huh? So a 45-year-old man presents with fatigue, weight loss, and hyperpigmentation. His blood pressure is 90 by 60 millimeters mercury. Laboratory findings reveal a serum sodium of 130 and serum potassium of 5.8. Blood glucose is 65. So here the serum sodium is what? It's a little bit low, and the serum potassium is a little bit high, and the blood glucose is towards the hypoglycemic side, right? What is the most likely diagnosis? Addison's disease, Cushing syndrome, hyperaldosteronism, pheochromocytoma.
Addison's disease.
Yes, Addison's disease. Very good. So primary adrenal insufficiency or Addison's disease is characterized by fatigue, hyperpigmentation, hypotension, hyponatremia, hyperkalemia, and hypoglycemia. A 38-year-old woman presents with nausea, vomiting, and severe abdominal pain. She has a history of Addison's disease. All right? Pay close attention, please. She has a history of Addison's disease and was recently diagnosed with pneumonia. Her blood pressure is 80 by 50 millimeters mercury. She's already shocked, yani, huh? What is the best immediate treatment? Oral hydrocortisone, intravenous hydrocortisone and fluids, fludrocortisone replacement, intravenous insulin.
intravenous
Intravenous
hydrocortisone.
hydrocortisone.
Yes, because she's now in stress. She developed pneumonia, so she needs to have, and she's already vomiting, so she needs stress dose of hydrocortisone. Very good. The patient is in adrenal crisis requiring immediate intravenous cortisone and fluid resuscitation. Oral hydrocortisone is insufficient in emergencies. Okay. A 55-year-old woman presents with fatigue, salt craving, and postural dizziness. Examination shows generalized hyperpigmentation. Laboratory results reveal plasma renin activity is elevated and serum aldosterone is low. Okay. What is the most likely underlying cause? Pituitary adenoma, autoimmune adrenalitis, secondary adrenal insufficiency, congenital adrenal hyperplasia. What is your answer?
Autoimmune adrenalitis?
Yes, yes, very good. So autoimmune destruction of the adrenal cortex is the most common cause of Addison's disease, leading to deficiencies in both cortisol and aldosterone. Okay, the student who was asking before. Okay, this occurs only in primary hypocorticism, not in secondary. Okay, a 40-year-old man with Addison's disease is scheduled for surgery. What adjustment to his medication is required perioperatively? Increase fludrocortisone dose only, double his usual hydrocortisone dose, administer stress dose hydrocortisone, no adjustment is necessary. What is your answer?
Stress dose hydrocortisone.
Exactly. Surgery is stress, okay? So perioperative stress requires increased glucocorticoid doses to prevent adrenal crisis. Fludrocortisone does not require adjustment during acute stress. It's only the hydrocortisone or the glucocorticoid, yeah, okay? A 30-year-old woman with newly diagnosed Addison's disease presents for follow-up. What long-term complication is she at risk for? Hypertension, osteoporosis, diabetes mellitus, thyroid dysfunction. She has Addison.
Diabetes mellitus.
Why?
Autoimmune. and
Thyroid dysfunction.
Thyroid
She-
dysfunction.
autoimmune adrenalitis. So it can be associated with autoimmune thyroiditis as well. Okay? Autoimmune adrenalitis is often associated with other autoimmune conditions such as Hashimoto's thyroiditis. Is it clear, Dr. Sama?
تمام.
Okay. Okay. Type. A 25-year-old man presents with hypoglycemia, weight loss, and generalized weakness. His morning serum cortisol is 3 microgram per deciliter. The normal is from 5 to 25 micrograms per deciliter. So it's low. Okay. What is the next best diagnostic test? ACTH stimulation test, dexamethasone suppression test, plasma-free metanephrines, 24-hour urinary cortisol.
Stimulation test.
Exactly. A low morning cortisol in the setting of suggestive symptoms requires an ACTH stimulation test to confirm adrenal insufficiency. Okay? Very good. A 60-year-old man with known Addison's disease is admitted with septic shock. He is hypotensive despite adequate fluid resuscitation. What is the next step in management? Vasopressors, intravenous hydrocortisone, fludrocortisone, insulin infusion. What is your answer?
Intravenous hydrocortisone.
Exactly, because he is in a stressful situation. He has septic shock. Very good. So adrenal crisis due to septic shock requires intravenous hydrocortisone to restore blood pressure. Fludrocortisone is not required in acute settings. Okay. A 35-year-old woman with fatigue and hyperpigmentation. Laboratory investigations reveal high ACTH levels but low cortisol levels. So imaging reveals adrenal gland calcifications. Here, you see, this is the image like I've shown you today, the last trip, and this is here the renal angle. The renal shadow is visible here, and this is the left adrenal and the right adrenal and the left adrenal. See, they are calcified. Okay, what is the most likely etiology? Tuberculosis, autoimmune adrenalitis, congenital adrenal hyperplasia, hemochromatosis.
Tuberculosis.
Exactly, tuberculosis. Very good. Adrenal calcifications with primary adrenal insufficiency suggest tuberculosis as the cause. Autoimmune adrenalitis typically does not cause calcifications. Okay? A 48-year-old man with Addison's disease is found unconscious. His blood pressure is 70 by 40 millimeters mercury. The blood glucose is 45 milligrams per deciliter. So he's shocked and hypoglycemic. What is the initial treatment? Oral hydrocortisone and glucose tablets, intravenous fluids and 100 milligrams hydrocortisone bolus, fludrocortisone replacement, intravenous insulin and glucose. What is your answer?
IV fluids. So
Exactly. This patient is adrenal crisis. Adrenal crisis requires immediate intravenous hydrocortisone and fluid resuscitation. Fludrocortisone is unnecessary in acute management. The last case, a 42-year-old woman presents with fatigue and hyperpigmentation. Laboratory tests show morning cortisol is low, ACTH is elevated, anti-21 hydroxylase antibodies are positive. Okay? What is the underlying pathology? Adrenal hyperplasia, autoimmune destruction of the adrenal glands, pituitary adenoma, adrenal hemorrhage.
Autoimmune
Autoimmune
destruction of
destruction.
adrenal gland.
Exactly, because she has the antibodies, Positive anti-21 hydroxylase antibodies confirm autoimmune adrenalitis, which is the leading cause of Addison's disease. Thank you very much. Difficult questions? Difficult questions?
Manageable.
Okay. Okay. So we finished. Alhamdulillah Rabbil Alameen. I hope you gained maximum benefit from the 3 revision sessions that I gave you over 3 weeks. Of course, interrupted, Yani. Please let me know if you need any further revision sessions before your exam. Your exam is on the 11th of January. I think, Yani, we have revised all the endocrinology, right? In particularly the imaging, because most probably in your upcoming OSCE, one of the stations will be imaging station, okay? So please, the imaging is very important. Is very, very important, okay? Any questions so far? Any problems?
دكتور شكرا جدا لحضرتك يا دكتور.
لا العفو والله العفو. I'm happy that I could be of benefit to all of you, Yani. At least I hope I could be, and I will see the problem of the first video, why it didn't open, and hopefully I will be able to upload the video of today's session as well. All right. Any final comments? Any final suggestions? Any final requests? Feel free. So I was happy revising endocrinology with you, particularly the imaging, and I wish you the best of luck for the new year, the coming new year, full of success, good health, and God's blessings, and all the good in the world. And of course, I wish you the best of luck on your upcoming exam, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you,
وعليكم
Doctor.
السلام.
I will see you next year, inshallah.
الله.
Bye.
مع السلامة.